So thank you for coming and being part of this event. So this is the first sort of antibiotic stewardship event we've organised here at the hospital. The Royal College of Physicians, Royal College of Surgeons, CPD credits pending, so we'll put a submission in for that, so you get your CPD points. And thanks to the sponsors for sponsoring this event. So we've got a diagnostics company and several pharmaceutical companies here who have sponsored this event to make it possible, to enable us to get this sort of accommodation and travel paid for the speakers. They are come from far and wide to be here. They've given up their time, but they've contributed to the venue, your food and speakers travel. So I really do thank them for that. Please do go and talk to them. We've got lots of new reps for those companies dying to meet you. Say hello. So please do go and say hello to those guys at the back. We've got a hashtag RCHT, Royal Cornwall Hospital Antimicrobial Stewardship, for you tweeters, please do. And this is being recorded. So Andrew Sim, our cameraman at the back there, is recording this. So it will be on the RCHT YouTube channel. So any sessions that you particularly enjoy and you want to take back and discuss with your colleagues, they will be available for you to do that. So please do. So a few housekeeping things. So message to the speakers, really. Acronyms. No one likes acronyms. It alienates people. It loses us. So please, if you do use acronyms, explain what those acronyms mean. But please don't use them. But if you do, do that. There's no fire drills planned. That's already happened. We've done the practicing for that. Toilets. Yeah, I was going to check that. Does anyone know where they are? You'll find them. They're out there. There'll be a sign. Sorry, I didn't mean to check that. And there's 2 scheduled breaks. 11:05. There's coffee and biscuits, and then lunch at 12. Lunch at 1:15. 45 minutes. So please go and talk to the reps. Talk to each other. And then coffee break at 3:30. I've got some cake for that to really get us through the afternoon, because it's a full agenda. I am aware of that. And you're going to be exhausted at the end, quite rightly so. And we have got some evaluation forms as well, so please fill those in. I'd be interested to know which sessions you liked, which ones you didn't like, what you might like next time if we do it next time. And just a reminder about the Antibiotic Guardian. If you're not aware of that, it's Public Health England sort of host that. It's an opportunity to go in and make a pledge to be an Antibiotic Guardian and sort of pledge what you're going to do towards a sort of antibiotic stewardship sort of movement. So just to put this in context then, get us all on the same page. So there's the UK 5-year antimicrobial resistance strategy, and there's also the 20-year vision around AMR. The 5-year strategy is our second 5-year strategy. We had a 2013 to 18 strategy. This is our second one. And just to tell you some of the sort of key things in the 5-year strategy, it's a huge document that talks about animal, human and environmental antimicrobial resistance. But just some of the key stuff in there is, there's an ambition to reduce the incidence of a specific set of drug-resistant infections in humans by 10% by 2025. So there's a list of drug-bug sort of combinations trying to reduce the incidence of, and also to halve the number of healthcare-associated gram-negative bloodstream infections. So that's some of the ambitions. To reduce antimicrobial use in humans by 15% by 2024, and a 25% reduction in antibiotic use in the community from the 2013 baseline. So we've already made some moves in reducing antibiotic use in the community, and there's been some good work happening in primary care to reduce antibiotic usage. We haven't been so successful in secondary care. I think Phil's going to talk about that towards the end. But it is an ambition of the Department of Health for us to reduce antibiotic use. And I do think it's within our gift to do that. And I'd also like to hear what you guys think about that after you've heard some of these sessions. A 10% reduction in the use of reserve and watch antibiotics in hospital. They're essentially our broad spectrum antibiotics, so our tazocins, meropenins, 3rd generation cephalosporins, those broad spectrum antibiotics, so to reduce those by 10%. To be able to support antibiotic prescribing through diagnostics, so making antibiotic prescribing decisions based on diagnostic tests or decision support tools by 2024. And again, this is something that you'll hear a bit more about throughout this morning. and to reduce antibiotic use in food-producing animals. And they've done some great stuff in the animal world, in the food-producing world, in reducing antibiotic usage, and Phil will touch upon that. But we've seen huge reductions in antibiotic use in that sector. So we're going to start this morning then with a session on managing sepsis, look at some diagnostics, some sort of new diagnostics that are coming and being trialled, some old diagnostics that we could do better at using. I've got a session on paediatrics and antibiotic stewardship from paediatrics perspective. Penicillin allergy is a big driver for broad spectrum antibiotics, so we've got a session on how we tackle sort of overuse of the penicillin allergy label. A session on shared decision making, clinical decision support, a session on the sort of 2 new papers around oral versus IV antibiotics showing sort of similar efficacy in treatment outcomes, and then a sort of roundup session at the end sort of to bring in how we're doing nationally with the antibiotic stewardship agenda. So your job then, you're not just sitting here, you know, you need to be involved. If you hear something that you believe will improve the care of patients here at this hospital, I really want to have a talk about that afterwards. We can discuss it during this session, but I really want us to, you know, outside of this meeting, to really sort of have a look at some of these things. You know, a lot of these diagnostics are fantastic, but they do need to be coupled with antibiotic stewardship and sort of, you know, patient pathways. So that's where you guys come in. So yeah, that's what I said. And also some of these sort of interventions and sort of ideas won't work as sole crusaders, if you like. We need to do it as a team, as a group, as a specialty perhaps. And if we like some of these ideas and these ways of working, you know, it's best to do it as a specialty. You know, the intensivists perhaps get together and think, you know, I quite like procalcitonin, let's get that in, all that sort of thing. And you know, with specialty leadership and specialty engagement, we're much more likely to bring some of these new things in.